because I'm not gonna go real heavy into it. I can't spend all day on anatomy and physiology, okay? So please take the time to review some of that information, and that will help you when it comes to the different types of cardiac anomalies and birth defects and changes, so that you have an idea of what holes are there, what holes need to stay there, what holes need to close, those types of things when we get into those different cardiac defects, okay? So, all right. The reading for this chapter starts out in chapter 4, where it's talking about growth and development and the heart assessment, okay? I would be very familiar with the areas that you listen to hear the different valves in the heart, because we're going to be talking about different malformations and malfunctions of the different valves. So know that all patients take meds and where those are, okay? The 4 chambers of the heart, the 4 valves of the heart, and what you're listening for, and what valves you're listening to. So if there's a murmur, you have an idea of where that murmur is located because of where you hear the murmur. So you can then figure out, oh, we have an issue with the atrium. We have an issue with the tricuspid valve, whatever. So you have an idea of where these holes are when we get to that. That's why this is really important for you to understand the auscultation of the heart, where we listen to the heart, and that type of thing with assessment. So make sure that you're familiar with the anatomy of the heart and the chambers, the valves, and normal blood flow, and all of that you're going to learn in those pages, okay? Let me put my slideshow up. Everybody see on the slideshow? Yeah? Okay, good. All right. So, so this kind of talks about the AOP review. I would also be familiar with cardiac output, what that is, as well as stroke volume. Not so much, there is an idea or definition of stroke volume that you kind of need to know, but preload, afterload, contractility, those are all terms you need to be familiar with, okay? I want you to know what those mean, what those are. Preload is how much is in the heart when it comes to fill. Afterload is how much is left in the heart after it pumps. Contractility, how strong does it pump? The actual pumping mechanism of the heart. I know you guys like to see the slides, but I'm also very expressive with my hands. So, and it's kind of up to you whether you want to see the slides or you want to see me, because I have a tendency to, be expressive with my hands. It's just up to you. I don't have notes on my slides, so you're not going to get a whole lot more than what's already in your work guide, okay? All right, so this is important to know, again, like we talked about, the importance of knowing the changes. This starts on chapter 27 in your textbook, okay? So chapter 27 is the main content for this lecture, and it's the information that you need to know. Is there a question? Good? Okay. So when we look at what happens in the heart, there are changes that happen at birth. Normally, the fetus receives blood flow from the placenta to the umbilical vein, to the ductus venus, to the foramen ovale, to the ductus arterius, to the umbilical artery. So it goes into the umbilical vein and out through the umbilical artery back into the body of the mom, okay? So that's placental blood flow. It doesn't really go into the body of the fetus very much. There is a small amount that does circulate through the fetus, but not very much. The majority of it just goes to the vital organs and then right back out to the mom. But when the newborn takes their first breath, okay, when they take their first breath, the umbilical artery closes, okay? So what does the umbilical artery do? The artery takes the blood flow back to the mom, right? So it stops taking blood flow back, and it closes. So then the blood stays within the fetus, the newborn. Then, after that, the umbilical vein and the ductus venous closes. So then, everything stops. Blood flow to the baby stops. Blood flow away from the baby stops, okay? So it has the blood flow in it. Once that happens, then the ductus arteriosus closes, which then increases the pressure in the body of the newborn, which causes the closure of the foramen ovale. Those closures of the ductus arteriosus, the foramen ovale, the ductus venous, separates the heart, the different chambers of the heart, and separates the pulmonary arteries and the aorta, which then leads to normal circulation. So let's take a little look at this, okay? So we see the blood flow from the placenta going up into the heart with just a little bit of blood flow to the rest of the body for the fetus, okay? But then as that closes, these are where the holes are that we see. There's a hole that goes here. That's the ductus arteriosus. That's between the aorta and the pulmonary arteries, veins, arteries. Yeah, they go to the lungs, the blood flow that goes to the lungs. There's a hole there between those two. So there's ductus arteriosus. There's the foramen ovale, which that is between the atrium of the fetal heart. And all of those close, so that then we have the normal blood flow where it comes into the right atrium. It's separated from the left atrium. It goes in to the right ventricle and then up into the lungs through the pulmonary system. Then it comes back in to the body into the left atrium, down into the left ventricle with oxygenated blood and out through the aorta to the body. Okay? So that's the way that works. So sometimes, and you'll see that sometimes we need this hole, this ductus arteriosus, to stay open so that we can have some oxygenated blood getting to the body. Okay, because sometimes if there's issues with the pulmonary system or issues with other places in the heart, transposition of great vessels, some of those things that happen, we need to keep this open so that then at least mixed blood gets to the body. We'll talk about that as we get further into it. But that's why it's important for you to know where those holes are and what they look like, so that when we get into what we want to do and why we're doing what we're doing, you need to have an idea of that. So for the cardiac assessment, it's really important to observe their general color, growth, behavior, mentation, recognizing that issues with cardiac affects the entire body, right? If your heart's not pumping effectively, you can have issue with oxygenation to your brain and to your body systems, to your bones, to everything that grows, and all that you need. The metabolism needs of the body are not going to be met if your heart's not pumping effectively or things aren't working right. You're not getting that oxygenated blood you need. It's important to question how they do with activity. Do they have activity intolerance? Do they sleep well? How do they sleep? Do they have to sleep with their head elevated? Do they sleep fine laying down? Do they, how do they sleep? How much fatigue do they have? Again, how much are they eating? Again, if you have some issues with the cardiac, recognize that you could potentially have issues with the lungs, right? And we know that breathing is more important than eating, with our ABCs. So therefore, sometimes they don't eat well because they get too tired. They have to stop and breathe. And squatting, when we squat, it reduces the amount of pressure from blood flow back to the heart. And so it takes off the workload of the heart when they squat, or they bring their knees to their chest if they're a baby. So are they squatting? Are they bringing their knees to their chest so that that relieves some of the pressure of the blood flow to the heart? It cuts off that blood flow to the lower extremities. It reduces that return of the blood flow back to the heart. Illness, are they getting sick a lot? Weight gain. We know that water weighs, right? So if we have a weight gain, and unexplained weight gain.
This is Highfield.
Yes.
Some students on Zoom and myself were wondering if lecture capture was recording.
Yes, it is.
Okay, thanks.
It's the blinking.
Also, Ms. Heitfeld, can you turn on your camera to your tablet so that we can see you if we want to?
I don't know how well you'll be able to see me, but sure, I can try. I'll try. How's that? Let's see if we can make it work. Okay, so anyway, weight gain, pain, and the page numbers that are listed in chapter 5 are about pain. And we'll hopefully get to that at the end of this lecture. We'll talk more about pain. But I did hit on pain some with broken development. We'll try and get a little bit more at the end of this semester, but at the end of this lecture, hopefully we'll get through that to that point. Okay. And irritability. Irritability is one of the first signs of a child not getting enough oxygenation. A newborn, a baby, they just get irritable. So that may be one of those things that can indicate we have some irritability. We're going to be looking for their appearance, the shape and the size of their chest, recognizing that with heart failure, with some of those, we get that barrel-chested look. That happens in children too. We're going to be looking at equal expansion. We're going to be looking for signs of the heart beating so strong you can see that pulse. Looking for that, some of that. We're going to look at the color of the skin. Are they cyanotic? The clubbing of their fingers, which indicates poor oxygenation to the extremities. Edema. We're going to look for neck vein distension to know how to do that. What position do they need to be in for neck vein distension? What do you think? What position do they need to be in to see that? Anybody?
Tripod or high powered?
You might see it, but I think when we're assessing, we really want them kind of at a 45-degree angle. Is the better for that. So, to actually see exactly how severe it is, so we'll be looking for that. Bruising, if we have some blood dystranges or pooling of blood, sometimes that can lead to bruising. And then the breathing, because oxygenation and the heart go together. We're going to palpate, we're going to percuss, and we're going to be feeling for thrill, the chest. We're going to feel pulses in all extremities. Okay? Know what those are called and where they're at. We're going to look at calf refill. How strong are their extremities? Those are things that we look for as well. And again, auscultate that heart. We want to know their heart rate, their rhythm, S1, S2, is it a gallop? Is it a murmur? What does the murmur sound like? Is it machine-like? There's one in particular that sounds very mechanical. It's a murmur, but it's a very distinguished machine-like mechanical murmur versus a typical gallop type murmur. So make sure that you're listening to that. Where is it? So you know where it is. Timing, where is the murmur within the S1 and S2? That gives an idea of where it's at. Make sure that you're listening to the heart long enough. Okay? How long do we listen to an apical pulse if something's irregular? A full 60 seconds, right? What's the quality of their heartbeat? Is it strong? Is it too strong? Is it beating out of their chest? Are their pulses bounding, or are they weak and ready? Quality. Monitor their vital signs. Blood pressure has a lot to do with cardiac work, cardiac afterload, and all of that has to do with blood pressure and the amount of pressure that the heart has to work against. So knowing your blood pressure, it's important that you know the blood pressure normals for age ranges in your kids. Normal blood pressure ranges for kids, the different age ranges, know those. We also check to see if all pulses and blood pressures are the same in all extremities, if they have a cardiac issue, because that can help us to differentiate and locate where the problem could be. We're gonna look for indicators of cardiac dysfunction, such as poor feeding, tachypnea, tachycardia, failure to thrive, poor weight gain, activity intolerance, developmental delays, prenatal history, and family history of cardiac disease. Recognize when you're assessing these, always prioritize your ABCs with what you address first. Okay, so airway, breathing always comes before we worry about feeding or history or anything like that. It's really about airway and how they're breathing, that tachypnea. We address those issues and look for that first when we're assessing and when we're addressing issues, right? It's always airway, breathing, circulation. So some of that stuff comes a little bit later because we need to breathe before we can eat. And a family history is always good to know. These are questions you're going to ask. But again, we want to prioritize the airway, but we still need to know family history. Lab and diagnostics. And I want to add one on here, guys, on a lab. I want you to know normal ranges for B, N, B. B as in boy, N as in Nancy, P as in Paul. B, N, B, brain natural peptide or something like that. It's not on there, so make sure you know it. But for labs, we're gonna look at the CBC, their ABG, their CMP, coagulation studies, we're gonna look at a UA. Why do you think we need to look at a UA? What is a UA? Come for a while. Can you tell me what a UA is gonna do?
Electrolyte imbalance.
Okay, it could indicate an electrolyte imbalance. What happens?
Flow to the kidneys.
Awesome, there you go. What happens when the heart doesn't pump effectively, right? The blood pressure lowers, what happens to kidney function? It doesn't produce, it doesn't go through, it doesn't work, so we're gonna see issues with the kidney. Good job, issues with the kidney. Electrocardiogram, an ECG or EKG, echocardiogram, which is what, Enid, what's an echocardiogram, what is that?
It looks at how the heart's pumping, sort of.
Looks at how hard it's pumping, and what machine do they use, what's another word for it?
Ultrasound?
Ultrasound, good, excellent. It's an ultrasound of the heart. And when we do that, now an EKG, that doesn't take very long, they just have to lay still and not talk for maybe a minute, right? But when you're doing an echocardiogram, that can take a little bit. So we need to make sure that our child understands that they're gonna have to lay still. And we need to come up with distraction techniques and things that can help that child according to their age. Recognize that we're gonna use those elements of growth and development and recognizing what these children need, dependent on their age and dependent on, how we distract them, how we help them through things. And all of that goes back to that growth and development lecture. So make sure that as you're thinking about these different things, you're thinking, how can I help a 10-year-old know what they need to do for an echocardiogram or a heart cath, right? How do I help a 4-year-old with an echocardiogram? How do I have them lay still for that time period while they're doing an ultrasound of their heart? Those types of things. So think about those things as you're going through, because that will be part of the test and things, understanding that you need to have, all right? So, cardiac catheterization, now recognize, the first thing we need to recognize with this is it's an invasive procedure, right? So we need to make sure that we have, consent. We also need to recognize what the child needs to know about it. And all of that depends on their age. Sometimes if they're little, are we gonna tell them everything we're gonna do? No, right? What do they need to know about it? If they're older, if they're an adolescent, we might tell them everything we're gonna do so that they have an understanding. So, recognize that. Know what a heart cath is. Know your pre and post cath care. Okay, so if it goes to the groin, we need to make sure that they're laying still, that we're holding pressure, we're monitoring for bleeding, no matter where it's at, we hold pressure, or we use pressure devices. If they go through the wrist, there's not as much issue with movement, but if they go to the groin, which a lot of times they do, because if they're doing a heart cath on a child, it's usually for intervention. It's to go in and actually close a hole, or help a valve, or do something along those lines. And so they usually go into the groin for a child. So they're gonna have to lay still for that time period, and educating them and helping them through that process and recognizing what they need is important. Support, teaching to the parents, teaching to the child. Okay, recognize with this, you also have to teach parents. So it's important that you're thinking about what you're gonna teach your parent that may not know what an echocardiogram or an ECG is, or a heart cath, or any of that. Angiography is pretty much the same thing as a heart cath, right? I mean, it's the study of the blood vessels of the heart. It does often use a dye, as cardiac catheterization does. But with heart cath, it's a lot of times, like I said, intervention, whereas an angiography is pretty much the study of the blood vessels of the heart using dye. Not as common with, they're not gonna call it angiography an intervention. They're gonna do an intervention, that's just a look, right? Does that make the difference to you? Okay. Exercise stress test, what does that look like? Okay, that's where we have them get on that treadmill and walk. So they can see activity intolerance and see what the heart is doing and how it's, and you can imagine we're not gonna use this in little ones, right? They're not gonna have to be old enough they can walk on a treadmill, and have the, coordination to do that. So you're probably talking school age or older. So with cardiac catheterization procedure management, make sure that we, like I said, we explain according to their developmental level, and they're going to be sedated as they go through it, and they are NPO prior to, because we don't want them aspirating. So that's education and prep that we need to make sure we're telling the child and the family. They can't have anything to eat or drink. Even if they cry and scream and throw a fit, they still can't have anything to eat or drink. Because it could cause aspiration, so make sure that we're educating them on why we're doing what we're doing. And that when we sedate people, these things happen, and that's why we do what we do. So make sure that you're thinking about that, educating on that. Again, post-procedural care, it's really important that we're keeping an eye on their pulses and the pulse oximetry. We're monitoring their heart for issues. We're looking for the pulses in the extremity. If we are not seeing or feeling a pulse in an extremity that has had a heart cath, we need to call the doctor. That's an emergency. If you can't feel the pulses in the extremity of which you've had a heart cath, then there's a good chance there's an arterial bleed. They're bleeding into the body, not down their leg, and we have an issue. If it's cool to touch, if it's cyanotic, be looking for those. Monitor your vital signs every 15 minutes times 4, and vital signs, that includes that extremity. Looking at that extremity every 15 minutes times 4, every 30 minutes times 4, etc. And make sure that the dressing is such that it's a pressure dressing, And if not, then we need to make sure that we're covering that and addressing the hemorrhage or potential hematoma that could form. We're watching for that, monitoring for that, we're looking at for that incision, okay? Every 15 minutes, every 30 minutes, we're looking at the extremity, making sure that everything is good. So we're keeping track of their INO. And if they are diabetic, we need to be monitoring their blood sugar because they've been NPO, okay? So we need to be thinking about that and addressing that as well. So this is some pictures of a child that's going through these different procedures. And so there are just some pictures to kind of show what it looks like. There's a little boy getting an echocardiogram. This one's got a portable heart monitor on. One for an MRI or CT scan, looks like an MRI to me. And then this one looks like they're preparing for some form of intervention. So I'm gonna talk a lot about heart failure here for a little bit, just because with all of our disease processes that we have that we're gonna discuss, I'm going to get to a point where I say, and then there's a potential for heart failure. And you need to know what that looks like ahead of time, because that's gonna be our main complication for every cardiac issue from here on out. Okay? So I want to talk about heart failure first, because like I said, you'll get to a point where I'll say heart failure. And I don't wanna have to go through that with every single disease process that we're doing. Okay. All right. My lecture capture is still blinking, we're still good. Okay. Heart failure. This starts on page 967 in your textbook. Pages in chapter 27 leading up to this talk about assessment of the heart. It talks about the different procedures that we just did, different things, diagnostics that we just talked about, okay? So all of that is there for you to look at, as well as table 27.1 talks about specifically what are the different procedures for cardiac diagnostics. And I would primarily stick to what's in the work guide for what you need to know, because those are the most commonly used, okay? But you can go through and kind of see some of the different things that are there and what to look for. And there's also a really good explanation of a normal EKG pattern. For this particular lecture, we will not have EKG strips, okay? I'm not going to throw EKG strips at you. So, you don't have to worry about that. All right, so. It's not COVID, it's allergies. Those are on dogs this weekend. All right, heart failure. So this occurs when the cardiac output does not equal the circulatory or metabolic demands. The way I like to explain heart failure is your heart is a pump, okay? I'm gonna switch over so everybody can see me. Do this. Okay. So you've got a top chamber and a bottom chamber of your heart that are constantly beating, right? So what happens with heart failure is that suddenly you get a whole bunch of blood that gets into one part of the heart and stretches that out, right? So it's pumping along and then it gets too much blood and it gets stretched out. What happens to a rubber band as it gets stretched out? It doesn't pop back as easily, right? So it's pumping along, it gets too much blood flow, and then it starts pumping as effectively because it gets stretched out. It tries to build more muscle, but muscle is less elastic and does not bounce back as quickly as normal cardiac muscle. And so as that muscle builds, trying to pump against, and it gets firmer instead of more elastic, So it kind of stretches out and it thickens. So between the stretching and the thickening, it doesn't pump as effectively. And if it's not pumping as effectively, right, then you've got issues with, is it going into the lungs? Is it not coming back? Because the heart serves two functions. It doesn't just pump, it also pulls. So as one chamber empties, it pulls blood from the body. It pulls blood from the lungs. It pulls as well as pumps. As it empties, it sucks in blood from the body. Well, if that's not pumping as hard, it can't suck it in from the body, right? It can't suck it in from the lungs. So what happens to the lungs if it's the lung side? They get filled up with blood and it doesn't pull it back out. So then what happens to your blood flow in your lungs? What happens to your body? You get pulmonary edema, right? And we all know that pulmonary edema is deadly. Kills us. We get pneumonia. If we're not pulling blood back from the body, we get edema, we get swelling, we get liver enlargement, right? And that's all because the heart is not pumping as effectively. It's not sucking blood in and it's not pushing blood out. Okay, so that's what happens with heart failure. Does that make sense to you? If it's right-sided heart failure, where does it pull blood from? The right side of the heart. Where does it come? Where's the blood that goes to the right side of the heart come from?
Your extremities.
Good, your body, right? Your extremities. So if you have right-sided heart failure, where are you going to see blood not return from? The extremities, right? So you're going to have your edema. You're going to have your liver enlargement on right-sided heart failure. It's not going to pull it out of the liver. It's not going to get it back to the heart like it needs to. You're going to have the edema. So you have that. Left-sided heart failure, where is it pulling the blood from? The lungs, right? So that's where you're going to see lung involvement. So if you have left-sided heart failure, you see more lung involvement. Now, left-sided can lead to issues with the right side because the left side takes it to the body, right? And so if the left side's not doing what it needs to do, you can have issues with the body as well, all right? So we look for its decreased contractility and a volume overload because it doesn't pump it out, so it stays in. It doesn't circulate it like it needs to. We can have severe anemia, acidosis, respiratory disease. All of those can affect your cardiac output. We can have issues with cardiomyopathy. Now, cardiomyopathy and Kawasaki disease, these are acquired things that cause heart failure. That's what that means. Okay, cardiomyopathy and Kawasaki disease can be acquired. You can catch those, and then it can lead to heart failure. Then it says on there about early and late findings, okay, assessment findings. It's important that we understand that early in heart failure, we're going to have a little bit different, it's going to look a little different than late heart failure, okay? Early, we're going to have some irritability because they're not getting the oxygenation that they need. We're going to have some restlessness, things like that. They may get sick a little more often. But as it progresses, then we're going to start to see more overload. We're going to see more breathing issues. We're going to see more things like that, edema, as it progresses. So there are definite early assessment findings that we need to be monitoring all kids that have had heart surgery, any heart conditions, and we need to be educating the parents on those. So again, this talks about the normal heart and see how it's stretched out and it tries to get thicker and it just doesn't work. Okay? It expands and does not contract like it needs to. is, CHF really vary a lot with age. It also varies with whether it's right or left-sided congestion, which I talked about just a minute ago. And with infants, you're gonna see poor feeding. Again, we prefer to breathe over eating, and it's a lot of work to suck. And they get really tired, and they just don't feed as well. The irritability, they'll have shortness of breath, and they have some excessive swelling. And then again, with left-sided heart failure, we can see an enlarged liver or edema.
Can you switch back to your slide, please?
Sure.
Thank you.
With older children, we'll see poor growth, we'll see the shortness of breath, exercise intolerance. It looks a little bit more like an adult with heart failure. In your older children, with your infants, it's gonna be that irritability, that difficulty feeding, that kind of stuff. But as it progresses with the older children, you'll see the edema, you'll see the liver enlargement, things like that. Make sure that you're getting a good history for your CHF. Find out if they've had cardiac issues in the past. Ask about any past cardiac heart surgeries, any diseases, any flus, any sickness, anything like that that could be causing their heart failure. Do your physical exam. We're going to be listening for crackles in the lungs. We're going to be looking for edema. We're going to be looking for cyanosis. We're going to be listening for any murmurs, anything that could potentially illustrate an issue with the heart. Okay? Vital signs. A lot of times with heart failure, our blood pressure is low when it progresses. Sometimes at the beginning it's high. If they're in overload, it may be high. But a lot of times as it progresses, that blood pressure lowers because the heart just can't pump because the blood pressure isn't as high. We're going to do the echocardiogram, and like Hannah said, it does show the ejection fraction, it shows the workload of the heart, it says how much the heart is pumping, it looks at all four chambers, it looks at the valves. It is a good indicator and diagnostic for heart failure. The echocardiogram is our primary go-to when it comes to heart failure and determining how much the heart is pumping and able to pump and the ejection fraction. We're also going to be looking at labs as well. We want to make sure that we're maintaining that hemodynamic regulation. Okay, so what that means is we want to make sure that the heart is pumping as best it can. So medications for that, what would be a medication that helps the heart to beat more effectively? Digoxin, right, good. Know everything about digoxin? Know everything about digoxin. There are books, there are pages in your book, or boxes in your book. Dig toxicity, dig dosing, page 974. Family-centered care, administering digoxin teaching on page 975. Know everything you can about digoxin. Okay? We want to make sure that we're keeping them oxygenated. With children, it's not as, you don't have, unless they are older children that have had heart failure for a long time, and your younger babies, you don't have that same heart failure, don't get their oxygenation level above 88 or 90 like you do in your older adults, because this is new to them, their body hasn't switched that mechanism of CO2 over. So we want to make sure that we're maintaining oxygenation and keeping their tissues oxygenated, okay? We want to weigh them daily. Everybody knows when you weigh somebody daily, same clothes, same time, stripped down just to a diaper is always best, a dry diaper at that. And if you get an erroneous reading or something doesn't seem quite right with a child, you weigh again, right? You don't just make a phone call to the doctor, looks like they gained 6 pounds overnight, and weigh them again. That type of thing, but we wanna weigh them every day, same scales, same clothes, same time. INO, we're watching for that edema, we're watching for that fluid retention. We're making sure that they have good kidney function. We're assessing their edema and their nutrition, making sure that they're eating properly, making sure they're getting in enough protein to help their body to heal and to meet the metabolism needs that they have. Okay? And then it's really important that we do a lot of education. A lot of education on potential complications, what heart failure looks like in their child, what to expect, what they need to call the doctor on. If they're weighing their child daily, when do they need to call the doctor? If they are noticing their child getting more irritable, and they're not pulling up their ears or don't have a stuffy nose or anything like that, or if they do, because from the illness, when do we need to call the doctor? What do we need to do to help them? If they have a heart cath, we want to make sure that we're teaching them how to care for that site. And discharge instructions, huge on any medications that they're given. If they're given blood pressure medication, if they're giving a diuretic, if they're given digoxin, what do we need to teach them about these medications? Okay? If they give the medication and they throw up, do we give it again? No. Okay? If they miss more than 2 doses, we need to call the doctor. Those types of things. Antibiotics before they go to the dentist. For anybody that's had heart failure or a history of heart disease or surgery with their cardiac issues, you want to make sure that they're taking antibiotics before they go to the dentist. Discharge instructions are huge. Okay? So make sure that you're looking at that, you're reading about that, and you're understanding it. And there is a care plan for a child with heart failure in your book. And for your assignment for this unit, there is a SurePath assignment. Now, it's not due till next week, next Tuesday, I think is when I made it due. But it's a SurePath assignment for you to do. Now, that is your assignment, not your attendance. Okay? We're gonna try doing attendance through a report that we can get off of Zoom now. So if I can make that work, then I don't need you to do anything on Blackboard. I'm trying that today, okay? When I come back on Thursday, if I have an issue, then I'll tell you and we'll have to do something different. We're looking for ways to make that easier for everybody, for us, for you, but that's kind of what we're doing right now, okay? So, I'm gonna try that today. And I forgot to tell my other counterparts at the other 2 locations, we just need to make sure that the people in class that are supposed to be in class are, so that we know who's not and that kind of thing, so when it comes to attendance. But that's okay, I'm gonna assume everybody's there. If somebody's not there, Enid or Commonwealth, will you let me know? Send me a message and say, so-and-so wasn't in class today, still 1 or 2. Because I'm not used to seeing who's here and who's not. I have gotten some messages from people saying they weren't coming to class today, so I am prepared for that. But if you look around and somebody's not there, shoot me an email and say, hey, so-and-so wasn't here, and I'll double check and make sure they were on Zoom. This report also tells me, just so you Zoomers are aware, it tells me how long you were on Zoom. So if you log off in the middle or aren't here for the whole class, I will know that. Because I'm sneaky. I'm pretty forthcoming. Okay, let's take a 5-minute break, okay? And come back and then get started again. 5 minutes, guys. I will